I think we can agree, and we talked about this a little bit before we started, that these are complementary rather than competitive. We each have our own opinions on a best modality. Let me just start with all three of us, and we'll ask the same question. What is this standard that we should do carotid revascularization for? In other words, what's the stroke rate, complication rate? And let's go through a little bit of the selection process of what you tell your patients with your modality, and when do you think that is best. So starting with you, what do you tell patients that come to you with carotid artery disease? What's their complication rate, and when do you recommend revascularization?
Well, obviously for symptomatic carotid, so a patient, the TIA or stroke, there is a clear indication if the patient have a significant stenosis to be treated. Then you will offer the different option modalities that are available. And as you know well, the gold standard still remain the carotid endarterectomy. I want to say probably I mentioned gold standard, or should I say old standard, but both are, and obviously there is the option to do a carotid artery stenting. The decision in the UK is based mainly on anatomy and a fitness of the patient. If the patient is fit for surgery and the anatomy is pristine, we're trying to do carotid endarterectomy. If it's symptomatic because the neck radiation or any other previous surgery in the neck, probably we prefer to do carotid artery stenting. And so carotid stenting, I have to say, unfortunately, in the UK is the second choice compared to open carotid endarterectomy.
Understandable and good points. And you're correct in that traditionally carotid endarterectomy has been the gold standard, and any of our technologies have to go and come closely to matching that before we should recommend that to our therapy. But things have been evolving in both the TCAR space and the transfemoral and transradial carotid stenting space. Michael, you're a vascular surgeon. You can do both the endarterectomy and the TCAR. In the United States, the TCAR procedure has really evolved and taken over a good bit of the carotid business. How do you determine if the patient is a candidate for either therapy? Please take us through your thought process of how you determine which therapy you offer a patient when you have both technologies to offer.
Yeah, Chris. So, I mean, in our practice, we really offer, and I personally offer all forms of carotid revascularization: transfemoral stenting, TCAR, carotid endarterectomy, and bolstered by the strong data supporting standard risk TCAR, both from the VQI and from the Roadster 3 registry. It's really moved up onto the menu in a much more prominent spot over time, TCAR has. So we'll look at patients and really based on more so surgical or anatomic risk factors, pick the correct procedure for the patient. For instance, of highly calcified lesion, we still will largely practice carotid endarterectomy in that patient. In a patient with a very shaggy arch, with amenable common carotid access, we'll recommend TCAR, and vice versa, for patients who have a very densely radiated neck or surgically inaccessible, even for something like TCAR, we'll recommend transfemoral carotid artery stenting. So I think that we're at a point where even our physiologic management of these patients has become so good and so standardized. I would tell you that the carotid endarterectomy of today is not the carotid endarterectomy that when I was in medical school, right? In terms of the outcomes, even the operative outcomes, et cetera. The anesthesia is so much better. Our medical management is so much better. But we learned a lot of that from, frankly, transfemoral stenting, the use of antiplatelet agents, Plavix on people having a CEA, all those sort of things. We've made these procedures so safe that we now, at the University of Rochester, use these anatomic criteria to decide what's going to give us that great outcome that the patient deserves, both asymptomatic or symptomatic.
You're absolutely correct, if I may. I mean, in 1991, NASH trial was published, and the stroke rate, the acceptable stroke rate at the time was 6%.
Right.
Now,
yeah.
if you perform a carotid endarterectomy with 6% stroke rate, you should stop doing
the procedure.
and endarterectomy. So, Mike is absolutely right.
And I think,
surgery has evolved. Stenting now is similar to surgery.
and I think you mentioned, both of you, that the carotid endarterectomy is not the same as it was then, and it certainly isn't. TCAR has come along, and I have to say, from a carotid stent standpoint, the carotid stent has come a long way as well. Back previously, there was no question that minor strokes were more with carotid stenting than they were for endarterectomy. No question. There are more MIs with the other, but maybe that's not as important when you're trying to prevent stroke. I think that we've really evolved in several areas, all of us, in terms of patient selection, who's a good patient, medical therapy that everybody's getting, whether they get revascularization or not. And with those lessons learned and the newer technologies, we've seen today that literally in high-risk endarterectomy patients, carotid stenting can be done with 1% or 2% at 1 year, which is pretty good in high-risk patients, most of those being minor strokes. And so I think all of us have evolved a long way in terms of what we're able to do and offer the patient. What do you take? We've talked about symptomatic. We really know we've got to treat those folks if they have a reasonable life expectancy. Let's switch gears for a moment and go to the asymptomatic patient, all right? Lots of controversy there. But if we can, any of us, we have agreed, we wouldn't do the procedure if you were doing it 6% or 3% for endarterectomy. But if you can do it, your procedure, whichever it is, with 1% minor stroke rate and, and good durability, what are you now telling a patient who comes to you with an 80% carotid lesion? How do you determine, what's your recommendation, and how do you involve the patient in that decision?
It's a very good question. In my opinion, for an asymptomatic patient, what really does matter is the morphology of the plaque. If you have a smooth plaque with severe stenosis, doesn't matter what you do. Stenting probably is less invasive, and with 1% stroke rate is a fantastic procedure. But if the morphology of the plaque is ulcerated, highly dishomogeneous, with a lot of porridge-like surface, probably I will be tempted to do the carotid endarterectomy rather than propose a stenting or...
Michael, same question to you. What do you think?
Well, I think that the long-term CREST data does support stenting and by extension TCAR in these patients as well. If you look at the restenosis rate and the clinically really actionable restenosis rate, like symptomatic restenosis, they really are the same with the different procedures using the CREST data. We'll still practice an anatomic decision-making process and recommend to the patient, if one of those is a clear winner, if you will, that they should be revascularized if they have a significant asymptomatic stenosis. And I think there's a lot of caveats to the run-of-the-mill asymptomatic stenosis. I think that you touched on, like, lesion morphology is important. I also think lesion progression is important. Sometimes if you're debating about a patient, if you should revascularize them, if they're a little physiologically ill and asymptomatic, it's pretty good to see that patient another 6 months later in the office and get another ultrasound and sort of see what's going on with the plaque and the patient's status overall. But I still think you can make an anatomic-based decision, because stenting has, be it delivered TCAR or transfemorally or transradially, has a great long-term durability from the data that we have.
Okay. Recently in the United States, as you know, and we'll share with you, that there was a national coverage decision that finally broadened the availability of carotid stenting or TCAR to the general population, whether they were standard risk, symptomatic or asymptomatic. And that's probably changed modestly the behavior in the United States in terms of the access. What do you think, what would you say, Michael, to Domenico, in terms of TCAR, your experience and your evolution, what do you think it would take to get the adoption in the UK and Europe to to where it is in the United States, and what would you say, and then what would you need to hear to convince you? Let's start with you.
I think it's going to be the NIH.
I'm very convinced.
I think that I think in my own practice, like when I same as I've had a pretty robust transfemoral carotid stent practice for a while too, and then when I started performing TCAR, I took the worst of the worst cases and tried TCAR on them, and frankly, that learning curve of 5 to 10 cases when you realize it's a highly reproducible, safe case, which you accomplished over the first 6 or 8 months of my exposure to the technology. Switch made me kind of a convert, and over time it became my preferred revascularization technique because it became highly reproducible, scalable to different OR and cath lab type environments, and it continues in our practice to provide a kind of 1% stroke rate in symptomatic and asymptomatic cases.
I like the word reproducible, which is the most important things. Because you can be Michael Schumacher or Formula One, but you'll be the only one. You know? So a technology to be reproducible by a wide spread of doctors, surgeons, cardiologists, they have to reproduce the same result. Otherwise, it's not going to be a valid technology with durability.
And when we talk about reproducible, one of the things that's important, first of all, it's incumbent upon all of us to not just do what I do, what you do, okay? Now, surgeons sometimes get in the habit of saying, I can do all three. All right, well, if you haven't done many transfemoral stents or you don't do them very well, maybe not a good idea. Similarly, I don't do an endarterectomy. I do TCARs with a surgeon. So the shared decision-making was part of the national coverage decision, which is a good thing. It means that all of us need to know the advantages and disadvantages of each approach and each approach in our hands, so that if you're a surgeon who hasn't done a transfemoral stent in 3 years, would you be comfortable sending it to somebody who did a lot of procedures? I'll ask a question to either of you. Would you be?
Your question is very valid. I will never do a transfemoral carotid stenting myself because I work very closely with the neurointerventional radiologist. They are definitely much better than me, and I prefer to work with them and be a team in the more holistic stroke approach. Obviously, TCAR has changed the paradigm here because it's more surgeon-friendly technique, and your catheter skill, they don't have to be so sophisticated. If you have to engage a difficult arch and go there, put the protection device. So I think all the three techniques are valid in the right hand of the right specialist.
I think you hit the nail on the head. You need to know your own centers and operators' outcomes to make this decision correctly. Right. So, and you have to step back and not have hubris that, you can do everything perfectly, or your partner can. You kind of need to know how the whole thing is going to play out at your institution. I think that the funny thing that if you look at transfemoral carotid stenting now in our practice, at our institution with our trainees, the case they want to scrub in now is a transfemoral carotid stent because we have TCAR and CEA that took over the vascular surgery space in the US, which is funny because that was something that we never would have predicted. So a transfemoral carotid stent comes up on the OR schedule and the trainees are clamoring on who's going to scrub on that, be they cardiology or vascular surgery trainees.
Take me through your pre-operative assessment. How do you plan for endarterectomy, TCAR? What non-invasive imaging do you rely on? And once you get that imaging, is there some characteristic that sways you in one direction or the other? Domenico, we'll start with you, please.
Well, we need to differentiate between symptomatic and asymptomatic patients. Symptomatic patients usually are admitted in a hyperacute stroke unit, and they will receive MRI, brain, and CT, and a duplex scan. So all the three modalities. Asymptomatic patients I usually pick up incidentally because a peripheral arterial disease or or symptoms that are not pertinent to stroke, but mimic stroke. And in this case, we'll do standardly a Doppler scan, but I always recommend an MRI because it's the only way to see if the patient has already experienced silent infarct and will be a stronger indication to support an operation or a stenting in this patient.
For TCAR, CT angiogram is essentially mandatory, is that correct?
Correct, yeah, and I think that the planning is best with the high-resolution CT angiogram of the neck and head to know the intracranial data. Certainly you don't need a circle Willis that's complete on all of these cases, but there are some isolated MCA circulations which may be higher risk for flow reversal. That's not necessarily been proven, but it gives us a little bit of pause when we're considering TCAR. I'm sure, I know your practice is probably similar when you look at those. And I think the other part about it is that TCAR caused us to homogenize our practice. So we had a transfemoral practice and a CEA practice that were separate. With the advent of TCAR, we work up everyone the same way. We put everyone on dual antiplatelet therapy. We do antiplatelet therapy testing, high dose statin. So it sort of changed things, and it probably raised all boats to some extent, that we probably did a better job taking care of the transfemoral stents and the CEAs through the mandated way that TCAR came out.
All right, you mentioned the isolated MCA, which none of us like with flow reversal. All right, when I do it, they're wide awake. They were looking at me, now they're yawning or whatever. All right, do you, for each of the procedures, do you do yours with patients awake or asleep? And if they're asleep, does it matter if they have an isolated MCA and it takes you 6 or 7 minutes to do the TCAR flow reversal? We'll start with you, and then I want to hear your opinion on awake versus anesthesia. But Mike,
our preference is to do the TCARs awake. We've actually recently published our anesthetic protocol, but it's essentially remifentanil low-dose propofol, so that they're conversant without the disinhibition that you can get under some sedative protocols. So when they're awake, it's the ultimate neuromonitoring, just like transfemoral stenting. The rubber ducky and talking to the patient is the ultimate neuromonitoring.
it is.
You know?
Yeah. Okay.
Well, make me laugh, this question, because I used to be a local anesthesia supporter, actually obsessed, and now I do all my carotid and the general. So I think there is no difference. And general probably use more shunt because you have to rely on invoice machine or stump pressure or whatever method of monitoring you are using. So there is, in my personal experience, there is no difference in my outcome. Obviously, local anesthetic make you feel better when you put a clamp in the carotid because you see the patient awake and talking to you. And the general, you need to wait until the patient is awake. But the Gala trial, it was a big trial done in Europe, show absolutely equivalent result between the two.
Chris, let me ask you a question.
Sure.
You just brought this up. One of the things that makes looking at carotid stent, like transfemoral, with percutaneous carotid stent literature difficult is it's apples and oranges in there. Because it's a lot of these trials are like looking at a specific stent performance, but don't necessarily have, are we looking at proximal protection, flow reversal, filter, how does it all work out? And it looks like if you can really make transfemoral carotid stenting incredibly safe, but I wonder in these trials, does the heterogeneous nature inside those carotid stent trials make it really difficult to lump all that data together? You've done this for years. What do you think about it?
It's an excellent question. The truth is, a lot of the protocols told you what device you got to use. If you're in a Sapphire WW trial, you use an AngioGuard and you use the Precise stent. Well, pick a name and it's the same. I think what's really going to be the home run is when we can individualize to each patient. And I really think that mixing and matching a distal protection and a proximal protection for some patients, you know, a closed cell straight stent for that anatomy and a conformable for something else makes it much better than some of the trials where we measured one technique and tried to apply it to a lot of patients. One of the other things, quite honestly, that's made carotid stenting results better now are the addition of screening committees like they did with TCAR, that now people can't put in bad patients into a clinical trial without it going through a screening committee. We should all be our own screening committee. But the truth is, doctors are not very good at that sometimes. And you've probably been on screening committees, and you see some of the cases that are submitted and saying, "Are you kidding? This shouldn't be in a trial, let alone getting a carotid stent or a TCAR stent or whatever it is." I want to ask you the criticism you're going to hear again and again and again is there's no randomized data. Okay, and I agree with your point. You made the number to because the event rate is so small right now. Nobody could afford it, and it wouldn't tell us anything anyhow. What is it going to take to get that argument to go away? What is the degree of rigor that would improve the perception of some of the TCAR data? What do you think?
Yeah, I mean, perception's reality to some extent, but I would say that perception is largely wrong, right? If you look at VQI, most of the data is based on VQI, right? And there's upwards of close to 100,000 carotid or TCAR stents inside of VQI right now. That is a registry, and albeit, there are the biases in the registry, but I think that those biases are actually against TCAR, to be honest with you, because, and the reason being is that only about 15% of the CEAs in the United States are inside of VQI right now. So that means 85% of what's going on in the carotid surgical space is actually unknown. So it's only, probably academic centers who are also including CEAs. Transfemoral stenting as well. It is multidisciplinary in there, but there are transfemoral stents that are not part of that database. So what you look at when you have VQI is that you have it's a vascular surgery initiated database at least, but inside there, those, especially over time, those were high-risk cases that were selected for TCAR, as they were for transfemoral carotid stenting in that database. So I think that the bias inside that database was already biased towards CEA, not towards TCAR, which has demonstrated very good outcomes. You can propensity match it all day long. You can't control for the eyeball test, and I freely admit that.
I think that are so strong now. We don't need a new randomized trial, Chris.
I think we've got enough evidence out there.
Yes, I think it's a waste of money. It will be many years. It will be obsolete. There is enough evidence that transfemoral and TCAR and carotid and arterectomy got the same result. The most important thing is select the right patient, because if you select the wrong patient for transfemoral stenting, you end up with a major stroke. Can I ask you a question to both of you?
Yes.
What is the learning curve of TCAR and transfemoral? How many procedures you need to be, perform in order to reach the reproducibility of your...
Michael, let's start with you.
I guess TCAR, obviously the literature says somewhere around 5 cases. In a practical standpoint, from doing these in an operating room, I did these with a neurosurgeon initially, alternating cases. It was about 10 cases when you said, okay, I have this down where the OR setup is the same every time. The nurses and the people know how to prep the device, that it becomes reproducible, somewhere around that.
And it's probably more for transfemoral stenting, quite honestly. Now, once you get there, I haven't had a rep, I have a rep there if they want to be there because they're a friend, but I don't need them. Whereas TCAR, a lot of people really depend still on the rep, so reproducible with assistance in some. But I think there is a learning curve for sure for all of our technologies. It's a minimum of 10 procedures on your own, but that's only after you've trained with somebody who really knows what they're doing. And I encourage all younger transfemoral stenters to watch and go with as many as you can before you go independently into a treatment that has somebody else's brain on the other end of the line for an unforgiving organ.
Tom, what do you think, as someone who trains surgeons too, how many CEAs to train a resident where you would close your eyes and let them just do the CEA?
Fantastic question. I test the trainee on the femoral and arterectomy first.
Okay, yeah.
And what I do, I have my own personal scheme. I let them dissect the carotid, but not do the endarterectomy until I can physically see that they are able to do the endarterectomy in the femoral artery. Then when they are semi-competent, I will be there for all the procedure. And I have to say probably 20 is the minimum. The learning curve, you are a surgeon as well, of surgery, I'm afraid is slower than endovascular. you learn quicker to, I don't want to say it's no super fast, but surgery will take probably 10 years to reach the full independence and be confident to do all the different procedures. And carotid endarterectomy is such a fine surgery because we are not curing anything. We're trying to prevent a stroke, but bizarrely, we can cause a major stroke. So,
and the truth is, even at our age and our experience level, we're still learning.
Yeah.
And that's why we're here at Charing Cross and others.
no, totally.
All right, let's wrap up on 2 questions here. We'll go one at a time here, and then we probably have used up our camera time. But I want one patient that each of you, for endarterectomy, for TCAR, for carotid stenting, where you say it comes to you, and I'm going to say the other procedure is better. What is the first thing that says, I'll start with you this time, Michael. What patient comes to you and you say, TCAR is not for you?
The access vessel, right? If the common carotid artery is not suitable and it's diseased, it can be short, but if it's highly calcified and you believe that you can't safely manipulate and get into their vessel, then, and if it's a high-risk patient, that patient should have a transfemoral stent, unless the arch risk is more prohibitive, and then you've got to figure out which of the two are worse.
Same question. What patient comes to you and you say, you need revascularization, but it's not going to be an endarterectomy?
If the patient has an hostile neck, so if the previous surgery or radiotherapy, definitely I would say you will be better suited carotid artery stenting or TCAR.
And I think for me, answering the same question, there would be 2 things that say definitely goes a different route, and that would be a severe concentric calcium that goes to endarterectomy, a very hostile diseased arch that would go to TCAR, and severe tortuosity would be an endarterectomy. It doesn't get a stent from any of us. Last wrap-up session, when you for each of you, say, why do I think TCAR is the best or my favorite strategy? Why do I think endarterectomy? Why do I think transfemoral? So, Michael, TCAR, what is it? Says this is what I want the world to know about TCAR.
All right, I think I said this earlier. It's incredibly reproducible. We have scaled it in our health system to all the hospitals that we operate at. It has the same 1% stroke death rate, and it is the same 45-minute procedure wherever we scale it to.
Okay, thanks. Domenico, what does the world need to know? Why are you an endarterectomy enthusiast?
Because I have the biggest practice of carotid endarterectomy in London for the last 15 years. I've done 1,000 carotid, celebrate the 1,000 patient recently, and my stroke rate is 0.8%.
Okay. And I would say the same. I've done more carotid stents than that, but the same idea. We're all high volume folks. And the truth, for transfemoral stenting, why do I love it? In the right patient, they're awake. I can evaluate them angiographically, neurologically. I can fix them if there's a problem. And it is also very reproducible if we each choose the patient wisely and we do the procedure correctly. So the beauty is 3 folks can have different ways of thinking things, but we all believe the same, that it needs to be done with quality and proven outcomes and individualized patient selection. So, well, I think with that, I'd like to thank you, Domenico, for a very collaborative effort.
Thanks,
Michael,
Chris.
thank you very much. And thanks to the audience for joining us here at Charing Cross. Thank you very much.